Good afternoon, all friends around this meeting. It's a privilege to be amongst a galaxy of speakers in this symposium spread over a fascinating range of issues. Congratulations to the foundation. I would like to focus only on child nutrition, given the available time and the focus that I want to bring in, and wish to focus again primarily on the implications for policy on some of the issues which I believe are consistently not on the radar screen, in spite of trying hard in a way. First, 3 points essentially. So, first point is, and that I'm taking cue and support also from what Dr. Kang had presented. I think first and foremost, in the context of undernutrition, in the policy discourse and stakeholder outreach discussion, general public space discussion, even serious policy debates, even serious program discussions, and at the state level, what is missing is that undernutrition has at least three mothers. It's first and foremost, it's about the real mother in terms of the fetal growth, in terms of having a normal size and length at birth, non-stunted, non-wasted, good weight babies is critical to start well in life. And it is often not appreciated that 20% of stunting, 25% of stunting, 30% wasting is really attributable to the very fact that the babies are born small. I'm talking here about fetal growth retardation, and of course, babies are small also. They are born premature, but essentially referring to IUGR. The second reason for being undernourished, stunted, or wasted is infections, which Dr. Kant has very eloquently explained. 25%, if I go by the overall literature, where it points to. It's about diarrhea, it's about pneumonia, it used to be measles, in another country it could be HIV-related issues and so on. It is really not appreciated that if you have to address undernutrition, primary health care, prevention of illnesses, and early treatment of illnesses, early care seeking is very critical. And I'll return to this in a minute. But the third one is feeding, real inadequate feeding. So what I hear in general discussion around ocean in policy circles is largely around feeding, and that also very often missing the point. And I'll come to that in a minute. I want to elaborate on this now. If we have to address uterine growth retardation, then we have to be mindful of the fact that there is a part of it which is really changing with time. Genetics is the same, but the epigenetics is not really the same across populations. And we carry the burden of epigenetics. We don't know how long it will take for us to overcome the epigenetic phenomenon. But certainly it doesn't happen with the next pregnancy, tomorrow's pregnancy in a woman. It has to be born in life. Then there is a scope of improving the growth of the baby in utero. But it cannot come only during pregnancy. If you're talking about feeding the mother, looking after her in other different ways, treating her own infections, anemia, and so on, it has to perhaps start in the earlier part of her life, at least in adolescence, even more so in pre-pregnancy stage. And then, of course, pregnancy. And in spite of doing all this, the change in the low birth weight that you expect, and thereby change in the low birth weight related stunting that you would expect, is modest. I'll come to WING's study, which actually provides some estimates of sort. I may consult a little note here. So it should be remembered that that part of undernutrition is to be understood differently. Often, the emphasis on infection prevention and treatment of diarrhea in particular, again, is I don't hear that often from the people who talk about undernutrition. I hear it from people who are in health very often, and they are pursuing health goals, but we need to bring it all together. We in Potion tried very hard to bring all the three. By the way, in Potion, we tried to change the paradigm by bringing to the fore the fact that there are these three mothers of undernourishment in children. So we tried our best to talk about zero diarrheal deaths, and by doing so, we also believe that undernourishment related to diarrheal disease will come up. We promoted hugely zinc, which I believe is the only drug treatment of undernutrition, because that reduces the duration of diarrhea and thereby nutrient loss and appetite gain. All that is brought back by zinc in time. So zinc must be a very important strategy when we are talking about undernutrition, but we don't hear it from the nutrition people. They, they don't see the connect. But certainly, under portion and linked to portion, India looked at universal rotavirus vaccination program. That was one gain the last couple of years, and the scale up has happened. Feeding and nutrition issues are only 50 to 55% of the people. And there also, it is two or three things are amiss. One is the timely introduction of semi-solid feeds at 6 months is delayed. It occurs, even just the mere introduction occurs in just about half of babies between 6 to 8 months. This is our CNNS survey. But when it comes to so-called adequate diet between 6 months to 2 years, we falter hugely. Only 10% children have what is known as minimum adequate diet. And that comes from CNNS. It's a 10% is the number that prevails, and none of our states crack anything above 15% or 18%. The point I'm making is that the notion of starting semi-solid feeds timed in a timely manner, this indicator is not moving optimally at all. And even when food is introduced, the optimality of the food is not on the radar screen, because that is a huge effort. And Wing study has tried to address that. It does need effort. So the point that I'm making is that in the policy and the program, the effort that is required to enable the family to feed the baby optimally in the later part of infancy and beyond, which means trying to push about 800 to 1,000 to 1,000 plus kilocalories, is something which is really not embraced by people. Not even, the fact that only 10% children have adequate feed by the UN criteria. All the surveys use that criteria. It is not something which is, data, like there is any problem with the indicator. It is something which is very standard. And other countries do much better on this. But this indicator refuses to move. In fact, the CNNS indicator was 6.4%. The NFHS4 was 10% order, 9 point something. The point is, we do not culturally feed infants optimally between 6 months to 10 years. And Dr. Soumya's teacher and my teacher, we also had common teachers, apart from being connected in a certain way in learning. Dr. Ghai used to tell us that a child at the age of 1 year has half the food requirement compared to an adult. And that's a lot of food. Try doing this, in front of your lunch plate and put half of it in the other plate and expect that 1-year-old child to eat it. This is really not in the culture. So I find this, Soumya, to be a very important part which is missing in our discourse. We try to change, but the changing the quantity and frequency and the mix of food to normal between above the age of 6, before it is too late, is really a big problem from my point of view. I also have not seen very exciting studies which change this indicator from 10% to 70%. Show me a study in this area where this indicator with even extra effort, even in a research setting, even in an NGO setting, has changed from 10 to 60, leave alone 80. I've seen some data which pushes it to 20%, 18%. And imagine the effort that it made. And how do you put this in the program? Where is the food? How the food is to be cooked? How do you educate the woman to feed the child 5 times, 6 times with the right amount of quantity, persistently taking a huge period of time? This to me, as far as a pediatrician, is very difficult for me to accept. And I want spotlight on this and colleagues to think about it. So my first point therefore relates on essentially saying that we must appreciate the role played by fetal growth retardation and how it can be and to what extent it can be corrected. We must appreciate that treatment and vaccinations, particularly diarrhea related effort, will improve the nutritional outcomes. And I'm pleading here that feeding is put in a very simple terms. Send the food home and the child will grow as it can happen. And then we go too far to say that we can have, kitchen gardens and then the child will become taller. There is a connect, but there is no proximate connect. And I think in the program, we are looking at change in indicators over a finite period of time. So that's my first issue with the policy discourse. The second issue is going forward on the low birth weight aspect. The optimality of feeding the low birth weight babies is not in the programs. Because what is the small baby supposed to eat? Breast milk, breastfeeding. How do we enable the mothers of small babies to optimally feed their kids? Expression of milk for a few days, feeding with spoon, kangaroo mother care. Nobody talks about this in the context of nutrition. We talk this in the context of neonatal survival. When I say nobody means in a general discourse. Yes, we are realizing it's important. So the importance of supporting small babies at homes through home-based newborn care model and more, and adding on top of that optimal kangaroo mother care is the way forward. Mothers need to small babies don't latch onto the breast. They're too weak to latch onto the breast. Mother has to express milk, and expression of milk would also require optimum breast milk output in the situation where the baby is not, making effort on the nipple, and then the hormone pathways are not activated. So this kind of a support is not vehemently supported by most people, even in the nutrition sphere. Who talks about this, aggressively? I'm sorry, we talk about lactation counselors, but that's about, a different kind of a support. Low birth weight baby feeding has to be center stage because this baby is already stunted or wasted. 16% of them already out there. And then they'll contribute to a quarter of stunting later on. So that focus, I feel, is something which is amiss. We try to correct it in the Poshan Abhiyan, try to bring focus, but takes a while because the nutrition programs are aligned in a somewhat different ways. This kind of a support, home-based newborn care, kangaroo care is spoken by the health rather than by nutrition. And I'm surprised why nutrition doesn't do it. And where is the worker to support the woman in the family? It's a big gap. We try to align and converge to Asha worker. Yes, there is a program. She's supposed to visit a few times in the course of the first 42 days, more so for low birth weight babies. Are we doing it optimally? Are we owning it up? Are we putting more effort on? Have we measured how effective this program has been from the point of view of nutrition? Also, last point I want to make on this, and some of you are aware of this, is the home-based newborn care came as a newborn survival program. The nutrition outcomes are not even measured in the original studies in a way. So, some of us came from that side, including myself, on the survival side. But that is the home-based care is the entry along with KMC for a critical care of low birth weight babies, and what you do in terms of feeding will also save their lives. My third point really relates to the issue of optimum access to appropriate food by the babies, and here we at times are distracted. I'm now talking about children who have undernourishment. Sometimes we use different terminologies to address this, but managing children with moderate malnutrition or severe malnutrition is an issue. Unfortunately, that is often not driven by science, and the science gets lost in the cacophony of ideologies. I feel very sad on this that we do not come together. Scientific community also does not come together. Scientific community changes positions for the management of such children. How should these children be fed? How should these children be stabilized? We may have made progress, but I also find that there is a need for us to have agreed protocols, how to support these children and how to demonstrate change that can be demonstrated. I know from the early data, the WINGS study, that when you put preconceptional care, pregnancy care, as well as early childhood care, it is possible for us to demonstrate a reduction in stunting in a matter of 2 years or less than 2 years. It is possible. Stunting can change dramatically. I look forward to using the data of the WINGS study for policy change. Uh, still, you know, I think we're still evolving with the right package of services around which we all come together and promote it. On the positive side, I hope that the Swachh movement would lead to less volume and burden of infections for children, on children, in children, and that should have a positive impact. But the worrying aspect is what we know from the some of the states for which NFHF 5 data is available, vis-a-vis 4, for some reason there are general declines in nutrition indicators, and we find it very difficult to sort to assign the reasons behind it. Maybe a deeper exercise is needed, but that's an important worrying point that I'd like to put on the plate. So in short, my message here is that for policy course correction and policy refinement, we must appreciate three aspects of undernutrition: the fetal growth, infection-related adverse nutritional effects, and of course feeding issues, and within feeding issues, the feeding difficulties of for complementary feeding and sustain optimum complementary feeding in poor households. And I'm also pitching for a strong voice and support for low birth weight care, which again is not fully supported.